Our second speaker is Dr. AzmeriSultana, Associate Professor and Head of the Pediatric Nephrology, Dr. Emar Khan Children's Hospital and ICH. She is one of the prominent pediatric nephrologists in our era and is making us proud. She has 60 publications and chapters in national and international index journals. Now I would like to request her to give her speech.
Thank you, Dr. Kana, for a great introduction. I'd like to thank organizing committee, especially Mamun sir and Misbah sir for having me here, and respected chairs, large audience. Today my talk is on peritoneal dialysis in children still is a prominent RRT option. Is it? Okay. So let's start with this picture. I'm sure the audience, everyone knows this person. So he's a former president of USA, Donald Trump, and he got trolled by saying this kidney has a very special place in the heart. Either he doesn't have anatomical clue about kidney or he really loves kidney. So this kidney may presented with acute kidney injury and we need to give support, kidney support therapy like peritoneal dialysis and other extracorporeal therapies. My friend Dr. Abdul Qadir already mentioned and explained nicely these extracorporeal therapies in children and challenges. And my previous speaker Dr. Saimul have shown nicely the challenges in pediatric transplantation. So next couple of minutes I am going to talk on the basic of peritoneal dialysis, why we shall choose peritoneal dialysis as a modality of RRT. I'd like to highlight ISPD 2020 recommendation. So AK is highly prevalent in children, especially who are critically sick. Among various kidney replacement therapies, peritoneal dialysis is the outmost used RRT worldwide. And there are many publications showed that for treatment of acute kidney injury, PD had similar outcome when they compared to the other extracorporeal therapies. So the basic mechanism of dialysis is when a dialysis occurs, either hemodialysis or peritoneal dialysis, there is a three basic mechanism. So molecule when moved from higher to lower concentration, that is diffusion. And when molecule water move from the lower to higher concentration, this is osmosis. And convection already nicely described by Dr. Kadir, that is a solvent drag solute across a membrane. So what happened in peritoneal dialysis? So peritoneal dialysis and peritoneal membrane contain 3-pore model system. So solute and water transport across peritoneal membrane through this 3-pore model. So large pore constitute the 2% of the total peritoneal surface area, and it allows only larger molecule like albumin. Then a small pore constitute 95% of the peritoneal surface, which allowed small solutes like urea, creatinine and electrolytes. Finally, aquaporine or transcellular pores, which contains only 2% of the peritoneal surface area, allows water to pass across membrane. So when we start peritoneal dialysis, we need to insert a peritoneal catheter. One side of catheter attached with the dialysis fluid and another end is a drain bag. So in PD, there is the basic mechanism, like we need to know about the fill volume. So what is fill volume? So amount of infused fluid or dialysis fluid infused into the peritoneal cavity, that is fill volume. And this dialysis fluid kept under the peritoneal cavity for certain period of time, that is dwell time. And after this certain period of time, these dialysis become effluent and then drain into a drain bag. So this is the basic mechanism of peritoneal dialysis. So let's have a look on this study. This is done by Rupesh Raina, one of my colleagues, and they compared the dialytic modalities in infant among the developing countries and developed countries. You can see here, let me start my laser pointer. So you can see here that the developed country, they used hemodialysis and CRRT, whereas in developing country, they mostly use peritoneal dialysis. So still peritoneal dialysis is using all over the world and commonest RRT. There is another study from Prof. Bradley. He is a renowned pediatric nephrologist from America. They included pediatric nephrologists from 92 centers from America and Europe, and they published this data that though they previously used peritoneal dialysis, but over the past years they switched to CRRT and HD. And they choose the dialytic modality also depends on the age of the patient. You can see here that when the child is younger, they still choose peritoneal dialysis, and when the child is older, they switch to hemodialysis or other extracorporeal therapy due to the difficulties in vascular access and anticoagulation problem in children, already discussed by Abdul Qadir. As of now, there is few data from South Asian nations. So me collaborating with India, Sri Lanka, Myanmar, and we formed our South Asian Aspire study. Unfortunately, this study is funded by our primary organization IPNA, and we trying to look out the epidemiology of AKI in this severe pediatric AKI, that is dialysis dependent AKI in this region. And we found, you can see here that most of the centers use peritoneal dialysis, that is 75% of the total data occupy the peritoneal dialysis, whereas CRRT and SLED are non-existent still. So when to start PD, it is the indication is same as other extracorporeal therapy like volume overload, which is not refractory is medication, then dyselectrolytemia, septic shock, and sometimes we choose PD in other modalities over other modalities when the child is premature or low birth weight neonate, infants after post-cardiac surgery, any bleeding diathesis, and cardiovascular instability. So whether we should start early or late RRT, there is a systemic meta-analysis which concluded that the early initiation of RRT doesn't affect the survival of critically ill children, though unless there is an urgent indication of the renal replacement therapy. This slide already discussed by our previous speaker. I would like to just mention the PD. So PD is easy to done, the cheaper. We don't need any vascular access, or we can even use it is in hemodynamic unstable patient. But the problem is we cannot predict ultrafiltration, and PD has some drawbacks like pericatheter leakage, catheter block, then increased chance of infection. So recent advancement of PD also overcome these drawbacks. Like if we use Tankov catheter or we use catheter by laparoscopy, then we can overcome this. And this automated PD, we can achieve our target fluid balance when we use this automated PD. And their decreased clearance also manipulated by the various dialysis regime like TD and NIPD. This meta-analysis published recently in Cochrane Library, they review and analysis and compare the peritoneal dialysis with the other extracorporeal therapy in terms of all-cause mortality and renal recovery, and they found little or no difference with peritoneal dialysis when compared with other extracorporeal therapy. You can see here the risk ratio is 1.12. So what does ISPD recommend? So when we should start a dialysis, peritoneal dialysis, we need to know the modality, we need to choose the solution, and then the field volume and dialysis prescription. So manual peritoneal dialysis has more chance of peritonitis, but it is inexpensive and easy to done. But automated PD, though it is expensive, but it has less chance of peritonitis. And its one drawback is that you cannot use in the smaller infant when the field volume is less than 100 ml. So ISPD also recommend the PD access should be Tankov catheter inserted by surgeon in a OT, and alternatively PD catheter can be inserted by the insertion kit with Saldinger technique. And in my center, still I use rigid catheter, though it is not a standard procedure. And ISPD recommend commercially prepared dialysis solution to be used, and in case of hepatic dysfunction or severe septic shock, you should use bicarb containing peritoneal dialysis. And what if any area don't have this dialysis fluid, you can make it from locally available solution, like you just take 1 liter of Ringer's lactate, then add 50% of 30 ml glucose. So initial field volume regarding peritoneal dialysis prescription should be 10 to 20 ml per kg, and gradually you should increase up to 30 to 40 ml. and fill volume should be 10 to 20 ml, total cycle should be 60 to 90, and gradually you should decrease towards a chronic prescription or switch to PD when the renal function is achieved. So while on PD, we should monitor the patient, closely monitor the patient for input-output chart, volume status, then monitor glucose and electrolyte regularly. So there is a large gap between my experience and execution of my training experiences. I got trained from NUH and got trained from Cincinnati Children's, and I learned about the CRRT, plasmapheresis, aquadialysis, but still I am doing peritoneal dialysis at my center. This is the data from our hospital, 5 years data. You can see that over the years, our renal disease profile, 10% patient include AKI, and among these 10%, 4% had dialysis dependent AKI, and you can see the most of the cause is infections, dehydration, multi-organ dysfunction syndrome, and out of these dialysis dependent AKI, 18% died due to AKI and PD related complications. In a nutshell, PD is a still choice of RRT modality in developing countries and as effective as other extracorporeal therapies. We need to train our healthcare provider, we need administrative support, and also government should run health insurance program. So I'd like to end here and wishing you Happy New Year. Thank you.
Thank you, Dr. Azmeri, for your nice presentation.